Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Ravi Viradia from Tennessee, United States. Dr. Viradia is one of the founding members of the Axon LLC. He is West Virginia University trained general surgeon, Yukon fellowship trained orthopedic hand surgeon, New York Columbia University microsurgery trained surgeon, and University of Tennessee plastic surgery fellow. He has published across several streams of medicine, including biomedical genetics, orthopedics, trauma, vascular bariatrics, PRS journal, ACS, and general surgery. He's been invited lecturer and guest speaker at multiple national meetings, including the Harvard Alumni Entrepreneurs, AAPI, and the American College of Surgeons. He has also been elected and delegate member on the House of Delegates for the Tennessee Medical Association. Dr. Viradia excels in medical and surgical innovation with a thorough background in the medical and surgical fields and an expansive network in the medical community nationally and internationally. Additionally, he has taken part in patenting orthopedic devices, accelerating companies, and developing protocols to enhance life sciences. So today, it's my great honor to introduce you Dr. Ravi Viradia from Tennessee, United States. Over to you, Ravi.
Thank you, Atesh. My name is Ravi Viradia, and thank you for joining us today. I've had a lot of experience in training under some big names in hand surgery. I was at University of Connecticut under Dr. Watson and multiple other attendings from all over the country who have trained many places. So thank you today for joining us. What I want to talk to you guys about today is basically complex areas of the wrist, specifically the DRUJ and the TFCC. So let's go ahead and get started. The first thing I want to show you guys is what we're going to talk about. So anatomy, pathology, getting the diagnosis, and then how to treat these wrist disorders. So the importance of the TFCC, also known as a triangular fibrocartilage complex, it's a cartilage structure, and it's located on the ulnar side of the wrist. It cushions and supports the small carpal bones in the wrist. And talking about the DRUJ, it is articulating with the distal RadioUlnar joint. And this joint is a synovial pivot type joint. It's between the two bones in the forearm, the radius and the ulna. The TFCC keeps the forearm bones, the radius and ulna, stable when the hand grasps or if the forearm rotates. So one of the important things about the TFCC and the DRUJ is when patients come in with falling such on their wrist and they supposedly have a distal radius fracture, they can have injuries to the TFCC and also to the DRUJ. This causes instability when they try to rotate their forearms or when they try to grasp objects, they get that pain right in the wrist area. To go into the functions of the wrist, and specifically the TFCC, as we talked about, it provides a gliding surface across that distal radius and ulna. It also has a mechanism of stabilization, and that is through that distal RadioUlnar joint, especially during that rotational movement of supination and pronation. It also suspends the ulnar carpus, which is the bones that sit on the ulna, and it also suspends it from contacting directly on the distal ulnar and radius. It provides itself as a pillow, almost like a cushion. And these forces that get transmitted through this go through this ulnar carpal axis, and it helps connect the ulna to that volar carpus. This is a good image that you can see here of the TFCC and how the ligaments and everything intertwine with the bones. So to go forward with the anatomy, the distal RadioUlnar joint allows us to rotate that forearm and to place that hand in that desired position when we perform different tasks on a daily basis. And it does this without interfering with the grasping function of the hand. So the ulna is the stable part of the forearm around which the radius rotates. That's very important to understand. The ulna is the stable part and the radius rotates around the ulna. The stability of the DRUJ is provided by those interactions of those ligaments, muscles, and bones in that area. The stabilizing structures of the TFCC, the ulnar carpal ligament complex, and the ECU tendon, as well as the PQ and the interosseous membrane, all these things work together to stabilize it. And there are several anatomical structures that stabilize the DRUJ. of which the TFCC, especially its insertion, is the most important. So the TFCC has this central articular disc, and it also has the meniscal homologue, as well as these ligaments, which are the volar and dorsal radial ulnar ligaments, the ulnar ligament and the ulnar triquetral ligaments, the tendon and the capsule. So all these work together to form this complex known as the TFCC and help with that stabilization. The importance of the TFCC, one, its stability, and it's an intrinsic stabilizer of the joint of the wrist. It consists, again, as you can see in this image here in the green and in the blue, of the radial ulnar fibers, as well as the two disc carpal ligaments, the disc lunate and the disc triquetral. The articular disc is responsible for transferring load from the medial carpus to the pole of the distal ulnar. The vascularized peripheral radial ulnar ligaments, which are in the green and blue, are nourished by dorsal and palmar branches of the PIA, the posterior interosseous artery, and they're responsible for guiding the radiocarpal unit around the seat of the ulna. Hence, the vascularity is going to be important here later in our talk, because this is going to help us in how to treat these type of injuries and what we can do about them. So the radial ulnar ligaments, as you can see here, help with pronation and supination. So concerning these ligamentous components, they are the major stabilizers of the DRUJ. Again, we talked about the dorsal and volar radial ulnar ligaments. These originate from the sigmoid notch of the radius and insert on the base of the ulnar styloid. So during pronation, the DRU ligament becomes tight while the palmar radial ulnar ligament becomes lax. During supination, the inverse occurs. This is of particular importance to the dorsal translational stability when the forearm is in pronation. So looking at the bones per se, this is an image of how the bones would look like, where the sigmoid notch is, where the lunate sits, and where the scaphoid sits, and the dorsal aspect where you can see Lister's tubercle. Again, it stabilizes during pronation and supination, and it's important to know these areas because of the insertions and origins of these different ligaments, as well as the TFCC. We talked about the arterial supply earlier. These are the palmar and dorsal branches of the anterior interosseous artery, as well as the posterior interosseous artery, which are involved with the vascularization. The central portion, which is very important to understand, is avascular. And so when there's tears in this area, this is going to come in to coincide with how to treat things in this manner. Looking at the nervous system, the radial nerve innervates the area via the AIN and the PIN, as you can see in this image. We talked about the pronator quadratus, and it also has a role in tensioning the distal radial ulnar joint. Both the deep and superficial heads of the PQ originate from the dorsal ulnar aspect on the ulna and attach to that palmar aspect of the radius. So talking about the distal radial ulnar joint stability, it can be due to traumatic injuries or chronic degeneration. Again, chronic and acute tears. The reason this is important is because this is all broken down into different types of categories based on whether this is chronic or acute, which we'll talk about soon. Some of the symptoms that you'll see in patients that come in with the TFCC injury is ulnar-sided wrist pain, that popping and clicking on pronation and supination, decreased movements and rotation, decreased grip strength, and that instability at that DRUJ. To diagnose this on physical exam, patients can sometimes have palpable tenderness over that TFCC. With combined ulnar deviation and pronation supination, this can cause that pain and that popping and clicking sound. You can also do these provocative maneuvers known as the TFCC stress test, as well as the press test, which can show up to 100% sensitivity for these tears. So what is the press test? Here, the press test shows a patient is asked to lift himself or herself out of a chair while bearing weight on the extended wrists. Pain at the wrist indicates a TFCC tear or a lesion. The press test is when the examiner also has the patient pronate both forearms and press into a table. So a positive test presents with that volar translation of the ulnar head. Other types of things you can do is a stress test or a ballottement. And this will show it to be positive if it's painful or at the DRUJ. You can do a radius pull test. And so with the elbow flexed at 90 degrees in the wrist in neutral. You're going to pull on the radius in the longitudinal direction, and you'll see some ulnar variance increase. This should be done under fluoroscopy so you can better visualize this. Clunk test as well as an ECU test, and again, that press test. The ballottement test is where you grab the patient's hand and wrist and you move the distal radius and the ulna separately to see if there's movement, that translational way. The TRUJ compression test is where you compress the radius and ulna against each other, and you also can rotate and supinate and pronate. The piano key is also another translational test, which the examiner has the patient pronate the forearm, applies a volar force to the ulnar head, and a positive test is indicated by that increased translation compared to the contralateral extremity. This is very important when you fix distal radius fractures, as after you fix the fracture, you want to make sure that the distal radius and ulna and the DRUJ is not coincidentally damaged enough to where there's instability. If there is, then typically there will be some K-wires that will be placed across the distal radius and ulna to help with stability and to help that joint and ligaments heal in place while also the distal radius bones heal. The positive fovea sign is tenderness in that soft spot between the ulnar styloid and the flexor carpi ulnaris tendon. This is really highly sensitive, as we spoke about earlier, up to 100%, 95 to 100% sensitivity of disruptions at the TFCC. Many people today, when they do diagnose or suspect that there is a tear, one of the best studies to really get is an MRI. Typically, you always want to get an X-ray on any type of hand injuries. This will help you kind of identify if there's any other etiologies, such as osseous arthritis. Usually these are negative. So the next step you would likely have in your arsenal would be to get an MRI. It's largely replaced arthrography, which was a joint injection under X-ray vision to show any extravasation between the compartments in that area, see if there's any tears subsequently into the carpus. An MRI is about sensitive to 74 to 100%. And then obviously the most accurate method for diagnosing this is a wrist arthroscopy. It's typically indicated in symptomatic patients after they've failed 2 to 3 months of splinting and activity modification. So here's an image of a ulnar type 1B, which is what we're going to talk about with the classification. It's where there's an ulnar avulsion of a TFCC injury, as you can see here on the ulnar aspect. And on the MRI, you can see that there is a lit up area showing the tear and injury going on in this patient. So this classification is known as the Palmar's original classification. It breaks it down into traumatic, which would be acute TFCC injuries, versus degenerative or chronic TFCC injuries. As we spoke about earlier, it's broken down this way to help with identifying where the tear would be and then how to treat it. Typically, they're broken down by anatomical subdivisions of radial, central, and ulnar tears. This classification bears consideration because the vascular anatomy dictates the potential of how much is going to heal and where you can treat these tears. As we spoke about earlier, the central portion of the TFCC is avascular, while the periphery is vascular. So this is going to come into account on how we treat these different injuries. So here's a good view of the type 1A injury, showing the lesions involving that central portion of the TFCC. The rim is still attached to the radius. This lesion is typically not amenable to direct repair, and arthroscopic treatment is limited to that debridement in the central area to remove any flaps that may impede movement. Here, type B is an ulnar avulsion, and it's shown in the peripheral area on the ulnar aspect where it's associated with ulnar styloid fractures. Type 1C is ulnar distal and involves the rupture of the volar attachment of the TFCC or the distal ulnar carpal ligaments, and there's variable amenable to repair. And then there's type 1D, which is the radial avulsion. These are typically rare, and there's tears at that radial attachment. These prevent with traumatic avulsions of TFCC to that sigmoid notch. Sometimes there's a fracture associated with that as well. So what are the treatment options? We spoke about the diagnosis, we spoke about symptoms. Now you want to see what we can do to help these patients. A lot of times they've seen their primary care doctors, they probably went to a general orthopedic surgeon, and they just chronically have these problems and they really don't know what else to do with them. So as a hand surgeon, typically we have a lot of tools in our arsenal to help these kind of patients out. especially when they think that they don't have anybody else to help them. Again, the first thing you want to do with any of these injuries, with a TFCC or DRUJ tear after diagnosing, is do a conservative management trial. What does that entail? It entails immobilization, as you can see with splints that cover the wrist and help with keeping the patient from using it as much, see if things heal. NSAID, so naproxen, diclofenac cream is great as well around the wrist. And then steroid injections to help with the inflammation, to see if that can help speed up and heal the surrounding tissues. This is indicated for all types of acute injuries, and it's also indicated as first line for the chronic injuries. Now, going into the operative side of things, surgical repair for patients is indicated when patients have an isolated or associated injury, significant instability of the DRUJ. Surgical repair of the DRUJ is contraindicated for patients when there's other pathologies evident, suspecting of radial or ulnar length discrepancy. So having positive ulnar areas in the bone with variance. DRUJ arthritis also would be a contraindication because there's other things involved and you may have to remove bone. Sigmoid notching incompetence, so where your ligaments and other structures attach. If there's incompetence, no matter what you do with the TFCC, you're not going to fix that problem. As well as ECU tendon subluxation. This is a separate etiology that needs to be corrected that will not help if you go after the TFCC and the cushion and try to either debride that central portion or repair the periphery. The reconstruction of the TFCC and the DRUJ often do not itself restore stability of the joint. And so careful patient selection needs to be carried out. It needs to be performed primarily as an adjunctive procedure to control pain. So when you ask these patients about their function, you really want to understand whether they're having pain and clicking while they're moving in supination, pronation, and their wrist injuries for the TFCC. If they're not having pain, there's really not a lot more that you would probably be able to do to fix their function per se. There's other things in literature that have shown reconstruction of radial ulnar ligaments and creating a sling per se. And all these procedures have their inherent limitations, but they've been found sometimes to help control the symptoms. So the first thing we talk about is arthroscopic debridement. It's one of the classic ways to repair a type 1A injury, which is that central portion of the TFCC on that central disc. As you can see here, you can get a blunt probe, almost like a right angle probe, and find where there may be a tear in the patient, especially found on an MRI, but definitely found if there is an arthroscopic video assistance. So you go through the 3-4 or the 4-5 portal, and this is how you can get the instruments into the wrist. When you're looking at it, you can go and probe the area and you can see the tear. So here is a demonstration of a right hand on the dorsal aspect where the radial midcarpal and the ulnar midcarpal portals are, and right below that is the 3-4 and the 4-5. Those are where you're going to place your incisions. Those are where you're going to place your portals to get into the wrist to help identify the TFCC as well as the carpal bone, radial carpal bones. One of the good things to find for the 3-4 is the Lister's tubercle. If you put your thumb there and then you find where your nail is and you pull it just forward about 1 millimeter, that's where your 3-4 is going to be. About 1 millimeter above that is your midcarpal portals. You're looking at the extensor compartment zones when you talk about the numbers here. So between compartments 3 and 4 and between 4 and 5. So here is a technique for maintaining that 2 millimeter periphery of the rim. You want to maintain that when you debride the central portion. You can get a debrider in there, which you see in the C here, and clean that area out. If you do happen to injure the periphery, then you can make the joint unstable. This again is not going to work in patients who have ulnar positive variants where their ulnar bone is sticking out. And so there's different things that you need to do for those patients. About 80% of patients obtain good relief of pain with this procedure as well. If you do have types 1B, 1C, and 1D injuries where you have the ulnar aspect of Volstagg or the radial aspect of Volstagg, you can do arthroscopic repairs where you have a camera that you see like you would in the type 1A and place basically instruments into the areas of the TFCC on the periphery, get sutures and do a repair by doing a U-loop and then attaching it through the bone. So you can have bone tunnels repaired, or you can repair them through the skin. Here you can see the image of placing the sutures in with needles, like an 18 gauge, and threading it through, and then bringing it back out, and then tying that U back into its place. And so what you end up with is basically a little incision here showing that sutures coming out like that. So we talked about the ONA and how it can be positive in variance. And so when you do have something like this isn't with a type 2 injury per se, and an ONA positive variance of greater than 2 millimeters, you can actually shorten the ONA. And so indications for this is a type 2 ONA with a positive variance of greater than 2 millimeters. And the advantage of shortening this and helping with the wrist is that it effectively tightens the ulnar carpal ligaments. And it's favored, especially when there's also lunotriquetral ligament instability, which is the lunate here in the triquetrum. When there's instability here in this area, it helps tighten things down. What this looks like on imaging, ulnar shortening osteotomy is what they call this. You identify how much the positive variance is there. You identify about in the mid shaft how much you need to decrease it back, which is normally to neutral. And then there's a plate, and then you place some screws as well as a lag screw across to help with stabilization. The approach would be from the dorsal approach to the forearm. You would do the osteotomy at the metaphysis, followed by plate fixation. It can address greater than 2 millimeters of ulnar variance. It does require immobilization and time for fracture healing, up to 4 to 6 weeks. And complications from this can be non-union for patients who smoke, as well as hardware irritation that may require removal down the road. There's other things you can do for patients with less than 2 millimeters of ulnar positive variance, and that is to go in and do a wafer osteotomy. This can be done for types 2A through C on chronic patients. Typically, you can do this open or arthroscopic. You want to take basically a chip, a wafer of bone at the distal segment to allow for the impingement to not occur. So an open wafer resection would be done from the dorsal approach to the forearm. You want to make sure that the ulnar cortex is not disrupted. Do not extend the bone removal into the DRUJ. Some pros and cons of this would be the intrinsic stability of the ECUA, the TFCC, and the ulnar periosteum. And you don't need to use any plates. So when you do just resect from the distal portion, you're not requiring any hardware. And so here's another way, and you can see here using a sagittal saw blade to get about 2 to 4 centimeters. You're being careful not to disrupt any of the TFCC, so you're underneath that. An arthroscopic wafer resection is where you go in and you do your central debridement, but then you also go in and burr down to the cortex, through the cortex into the cortical bone. And then you can remove approximately 2 to 4 centimeters of bone underneath that. One of my attendings when I was at University of Connecticut would do this arthroscopically, and it did great for his patients. The whole debate about arthroscopic versus open is still ongoing, and there's no consensus recommendations on whether these injuries should be treated open or arthroscopic, not just for the wafer resection, but all in all. Mainly though, these days people are doing arthroscopic because it doesn't require a huge open incision. It's minimally invasive. It takes 30 minutes to do in the operating room if you have the right equipment, and you can readily and easily diagnose patients. You can also get into the mid-carpal joint to make sure there's not any arthritis occurring above, and it helps with diagnosis as well as treatment. For patients that need to resect more the distal 1 to 2 centimeters, so you're talking a lot more bone, and there's really bad DRUJ arthritis going on, and they're just not able to supinate or pronate, it's chronic, you can remove that distal portion of the ulna. It's called a Derrick procedure. And you want to approach this dorsally. It's really good for elderly patients. And you resect that 1 or 2 centimeters and distal ulna. And then the TFCC, you want to approximate to that wrist capsule. It's a salvage procedure. It's only for pain relief. It's when the distal joint is unstable. And you want to leave that styloid process, muscular attachments intact. Some complications could be ECU, tendon can start to sublux, ulnar impingement syndrome, you can have loss of grip strength, and ulnar translation of the carpus. So here's another image of all of that as well. We talked about impingement earlier. So if you do that and there is impingement, it kind of impinges on the radius here. And this occurs when that stump of the ulna goes to the side. It's accompanied by instability. It's a major deforming force. And so when this occurs, you need to be careful about that there. You can actually curve the ulna in a way where you kind of shape it so that it kind of rotates around that sigmoid notch. So you can actually curve this down in a manner. It's called a match procedure, and Dr. Watson had helped develop that. So what happens if it's not TFCC related? Say you have some patient and you've done an MRI, you've done the scopes, you can't find a tear. Well, one thing to think about is tilt, which is triquetral impingement ligament tear. It has to do in 1999 when Dr. Watson and his associates found a new cause of ulnar-sided wrist pain. And it has to do with the triquetrum impinging on the ligament and basically this leading to chondritis. Patients present with this ulnar-sided wrist pain and they get this moderate to mild decrease in wrist extension, flexion, and grip strength. They have that point tenderness over that dorsal ulnar aspect of that triquetral bone. And there's a triad for diagnosis. It's localized triquetral pain, history of wrist hyperflexion injury, normal radiographs, and then it's accompanied by swelling at the ulnar wrist and limited motion. And so the mechanism of injury is a cuff of fibrous tissue develops and it causes a displacement distally from the ulnar sling mechanism, as you can see here. And it results in this chronic impingement and leading to a hyperanemia, loss of articular cartilage, and softening of this bone, as well as a tear. So what do you do about this? You have this presence of this redundant soft tissue mass that impinges on that dorsal triquetrum. And it's important, that's an important pathogenesis. So you want to remove it. You want to simply excise that impinging fibrous cuff. So when you remove that cuff, it helps prevent constant tension in this area. So an outcome of 44 patients that were treated for tilt over a 6-year period showed that in all cases, it resulted in improvement of wrist motion and strength. And 95% of the patients reported significant improvement in pain, both at rest and activity. So in an MRI, at times you can see right here that this is occurring. So when you do see this on a triquetrum, and you do see that there's a area here like that, that's something to think about. So that's all I have. Thanks for joining today and listening to me, and hopefully you've learned some things to help treat your patients for these wrist syndromes that they may be coming in with for TFCC and DRUJ.
Thank you, Ravi, for that brilliant presentation and excellent lecture and coverage of the topic. A couple of questions, Ravi. Do you think there's a role? I mean, you mentioned about arthrogram as well as an MR as an independent one. Do you think a combination of an MR arthrogram could be a more specific way to identify a TFCC injury before going in for a surgery?
I think it would be beneficial. It's just the cost. So cost prohibitive wise, even if you have a diagnosis that you can see, you still need to do the surgery for it. So if you just go right ahead with getting an MRI, which is much faster these days to do, and then do a scope, I think that would be the best way to go about it. Just wait for the scope, obviously. If the patient fails the trial of NSAIDs and all these different things, then go in with the scope 3 months later or so is what I would do. So I would do the MRI and then I would treat the patient for the diagnosis and then see if they get better, then scope them.
Thank you, Ravi, for that. And you mentioned about wafer resection, right? So is it known after Watson himself? Watson's wafer resection, if I'm right?
I believe the tilt he did himself. I believe the wafer was by somebody else. I think one of my attendings that did the wafer resection arthroscopically trained at Duke. So I'm sure maybe he may have.
And do you think there's a risk for an iatrogenic TFCC injury when you do an open wafer? In that case, do you think an arthroscopic wafer has an advantage?
Yeah, so when I was in training, we only did arthroscopic wafer resections. So I never saw the open version, but I'm assuming you're correct. I think when you go in open on the dorsal aspect, you have a lot more area of chance of injury. because you're dealing with a small area and you have all these ligaments right in front of you. So where are you going to cut? You're going to have to cut either in a translational, not longitudinal, but across horizontally sometimes, or go between those fibers. So yeah, I think arthroscopically, it's a lot safer.
Thank you, Ravi. Just one last question before we wind up the session. You mentioned about Dirac's procedure. I mean, it's a great salvage option. And one of the problems with the Dirac is the prominent stump, right? And to reduce the problems of impingement and subluxation, do you think looping a tendon, one of the tendons partially split and looping into the distal prominent ulna would reduce the problems of impingement and subluxation?
Absolutely. You can actually use the distally based strip of like the ECU to help with stabilizing that in that area, or even a tendon, and do like a bone tunnel across. One thing that Dr. Watson had developed, and I talked about it just briefly, was the ulnar match procedure. So instead of taking the whole ulna back 2 or 3 centimeters, you start at that radial styloid and you make a curve kind of like a banana, and you help that articulate on the sigmoid notch. So like now you still have the attachments distally at the ulnar styloid, but you're going to curve it across from ulnar to radial, still keeping your ulnar column. And that allows that curve to kind of help with pronation, supination with the radius around it. So now you've shaped it to that sigmoid notch, and it allows you to keep your stability and helps with impingement.
Thank you, Ravi. I think that's all the questions that we have for this session. Fantastic lecture. And I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much for joining in, Ravi.
Thank you, Atesh. Appreciate
Bye.
you guys a lot.